I'm interested in vaccinations as a medical intervention primarily because they're preventive. My background and my training is in preventive medicine, the ability to prevent a disease before it occurs, and that's what's key to vaccination, is that it's a way of making sure a disease never occurs in the first place. Obviously, illness is a burden that we all have to face. We're always going to need curative medicine. We're always going to need therapeutics to ensure a healthy lifespan, but why not emphasize as much as possible on that which can prevent disease before it occurs? And that's what vaccination is all about. There definitely are challenges to that. It's hard to tell someone to take something, receive an intervention if they're not sick, but that's the whole key to vaccine, is to use the product before they become sick. So that is probably the primary reason why vaccines are interesting for me. I did a few years of pediatrics before focusing on preventive medicine, and of course vaccines by their history originally were a pediatric practice. Of course it's more of an adolescent and adult now, or I should say that we are vaccinating more adolescents and adults than we did previously. Most vaccines are still used in a pediatric context, but I've always kind of been interested in using medicine where you get the most yield, and that is with the children, and it's always a better prospect to prevent a disease from occurring in the first place. You know, even though measles and polio are eliminated from the United States, and we don't see much mumps, there's no reason why we wouldn't start seeing these diseases again if people stopped vaccinating. We actually did have an outbreak of mumps in 2006 with over 5,000 cases, so that disease still occurs. We need to vaccinate to prevent mumps. We also have seen outbreaks of measles in the United States, multiple outbreaks primarily in California in 2008, measles that was imported into the United States from various countries, Switzerland, Israel, Belgium, Italy, India, bringing the measles virus into communities where there were families that applied vaccine exemptions. They didn't vaccinate their kids, and that allowed measles to get a foothold and to spread. So polio, likewise, we don't see it in the United States, but there are still, of course, cases that occur. It's still endemic in 4 countries of the world. Other countries use a lot of the live vaccine, and there have been cases, U.S. residents that travel abroad that develop polio from either wild-type polio or the live vaccine, based on the live vaccine. So these diseases still are out there. They could definitely come back. The term elimination, when you say a disease is eliminated, it means regionally. It's not worldwide. We use the term eradication for the worldwide removal of a disease. But for these diseases we've talked about, measles, polio, they're eliminated from the United States. They can still be brought into the United States, and people that are in the United States are still at risk. So we need to vaccinate to prevent the diseases. Smallpox is the one disease that has been eradicated from the planet, and it was through the use of vaccination. The smallpox vaccine is how we were able to accomplish that feat. We are still working on a number of other diseases, namely measles and polio, trying to eradicate those diseases with vaccination. We've accomplished this for measles and polio in the United States, polio in 1979, measles in 2004. 2000, measles in 2000. So we're working on it with continued vaccination, and it's not just a U.S. effort. It is a global effort to eradicate these diseases from the planet, but we need to do our part in the United States. Herd immunity, or sometimes we use the word community immunity, same thing, herd immunity, community immunity, is the concept that you don't have to vaccinate 100% of the population to prevent the spread of disease. For instance, if you vaccinate an individual, they cannot, or the vaccine will prevent that individual from getting the disease. Nothing's 100%, but it should work towards preventing the disease in that individual. That individual cannot transmit the infection to other persons, so those other persons also now cannot get the disease as well, and they weren't vaccinated. That's, in essence, community immunity or herd immunity, the act of being able to provide immunity without having to vaccinate everyone. And that's very important because not everyone can receive a dose of vaccine. Some people have medical conditions, which we call contraindications, so they cannot receive a dose of the vaccine. Well, we can still prevent disease by vaccinating persons that do not have a contraindication, and it's very important for those people to get the vaccine, not just to protect themselves, but the other people around them. For certain diseases, we know that the microbes that cause these various diseases have different transmission rates, different ease with which people spread the disease among other people. And so for some diseases, that transmission rate is very, very high. Measles is an example of that. Pertussis is an example of that. You really need to establish vaccination levels of 90% within a community to prevent enough individuals from being infected to prevent transmission of the organism. And so with diseases like that, you have to achieve 90% levels. We do that with measles essentially in the United States. We don't really get there fully with pertussis. So pertussis is still a disease that's uncontrolled in the United States. It can be with vaccination, but we're not there yet. We need to achieve those higher than 90-95% levels of coverage in order to prevent transmission. And it just has to do with the nature of the organism, the ease with which it spreads. So challenges for achieving high enough levels of pertussis vaccination include the transmission rate, which facilitates the spread. So you need to vaccinate large numbers of people, and so that's hard to do for any disease, but it's important with pertussis because the ease of transmission. Another issue with pertussis is historically we have used a vaccine to prevent pertussis only for children from 2 months through 6 years of age, and not for children older than 6. And so we've had this infant young child pertussis vaccine called the DTaP vaccine combined with diphtheria and tetanus, and we haven't been vaccinating to prevent pertussis in individuals older than 6. And what's happened with pertussis is we've found that protection provided by the infant vaccine wanes over time. The antibodies that you develop when you receive a vaccine, you lose those antibodies over time, and so your protection goes away. And so that's why we are now seeing adolescents with the disease pertussis, and we know that those adolescents can spread pertussis to their classmates, to their housemates, to younger children, in fact. So that's another thing that we're seeing with pertussis as well. Also with pertussis, there may be factors such as new diagnostic tools. We can detect more pertussis now because we have better technology. We're more strict with our surveillance definitions of what pertussis is. More and more providers kind of know to look for it, and so that's another. So those two factors are kind of perhaps artificially inflating rates, but I think there's also the truth behind that is that there are more cases of pertussis because of the other things we've talked about. It spreads really easily, and protection from the infant vaccine has waned. We have seen outbreaks of pertussis in California and South Carolina, statewide outbreaks. We've also seen regional outbreaks in Michigan, New York, North Carolina, Ohio, and Georgia. So we've seen them in many states in the United States. We think that some of the cases that have come to public attention, the deaths, there have been deaths of infants in California because they were too young Either they were too young to receive all of the doses of the vaccine, or they just didn't receive it. There were access issues to receipt of the infant pertussis vaccine. So we think that those 11 deaths, some of them at least, are due to that cause. But we also kind of know that behind all this, there is a need now to vaccinate not just the infants and the young children, but the adolescents as well. And we have now a vaccine to do that. When the pertussis outbreaks occurred in 2009, 2010, CDC kind of made a decision to expand this recommendation, and they have done so. Now, pertussis vaccine, and we're talking about the adult pertussis vaccine, Tdap, is recommended for all persons 11 through 64 years of age without regard to the interval of the last tetanus toxoid-containing vaccine. The benefit of preventing pertussis and preventing the spread of pertussis to these infants outweighs any risk of a local reaction. So that was a new recommendation to disregard that. Additionally, while the vaccine is only licensed down to 10 years of age, CDC made a recommendation that for all children 7 through 18 years of age, if they did not receive complete infant vaccination, if their history indicated that they did not receive a complete series of their infant vaccine, which is equal to 5 doses or 4 doses if you get the last one after the 4th birthday. If they're incomplete, then they should receive a dose of Tdap now. So you can see that for the 7 to 9-year-olds, that's an off-label recommendation that CDC has made. And then finally, the last part of this new pertussis vaccine recommendation is a recommendation for adults 65 years and older. If they have contact with an infant or anticipate having contact with an infant, that adult should receive a dose of Tdap as well. It's still a one-dose recommendation for everybody. For all these groups, it's for persons that have not already received Tdap. But the point is that now is the time to get a dose of Tdap. It's really based on our history with these outbreaks. As far as making a vaccination guideline, the CDC uses a non-federal governmental organization. Many government agencies do this, actually. And for the CDC, what happens is that we nominate members to an organization called the Advisory Committee on Immunization Practices, or ACIP. The parent agency of CDC, Health and Human Services, then picks the members on the ACIP. They are, again, non-federal governmental persons from the private sector or the public sector that are experts in vaccines and immunization. These individuals meet in Atlanta 3 times a year. Between those meetings, the ACIP breaks itself down into work groups that focus on particular vaccines. So when a vaccine is licensed by the FDA, the ACIP gets to work, forms a working group. The work group meets. It consists of ACIP members, a CDC lead, and other interested volunteers to the work group. They discuss issues such as the burden of disease, who the vaccine should be recommended for, the efficacy of the vaccine, how well it works, how safe the vaccine is, and other cost-effectiveness issues in terms of the cost of actually being able to provide this vaccine in the public sector, given the price. So all those issues are discussed in the working group. The working group then brings this information to one of the 3 yearly meetings, and the ACIP at large will take a vote on various aspects. CDC work group will then craft its recommendation and will publish it in the Morbidity and Mortality Weekly Reports. So that essentially is the process. It involves both federal government and a non-federal governmental advisory group. Once a vaccine is licensed, the federal government does a lot to ensure the safety of the vaccine. First of all, before it's licensed, it undergoes extensive testing of the vaccine, not only in the laboratory, but on animals as well as in people. Tens of thousands of people are usually involved in pre-licensure trials. Once a vaccine gets licensed, it does not stop there. The FDA, first of all, sometimes requires manufacturers to conduct additional trials involving usually an additional 10,000 people. That's generally the size of the post-licensure trials. And of course, this is to look for side effects that may be too rare to be picked up in the pre-licensure trials. Those occur. Additionally, safety surveillance begins. And in the federal government, that's conducted in partnership between the FDA and the CDC. There are a number of surveillance systems that exist to do this. One is considered a passive surveillance system. It's basically a system whereby providers can report to CDC and FDA any outcome that can occur following a dose of a vaccine. It's basically a huge safety net that is opened up to detect any possible outcome that could exist. Doesn't mean the outcome is caused by the vaccine. It just means it was reported. After that, the CDC will, along with the FDA, will use another surveillance system called the Vaccine Safety Data Link. This is a product that uses health maintenance organizations. There are 7 or 8 of them in the United States that basically collect information on people that are part of the health maintenance organization, and it has history of vaccine doses or whether they didn't receive a vaccine dose. It also collects history on outcomes on the basis of all the medical visits that occur in that HMO. All of this information is collected in a large database, and these databases are then linked together and allows the Vaccine Safety Data Link to look at persons that receive vaccine, persons that don't receive the vaccine. And that's a very important distinction because you're going to look at outcomes that occur among persons that both did receive the vaccine and did not. You have to do both sides of that equation to know whether an outcome is caused by a vaccine. It's an important next step to follow the passive system. And I don't know if I mentioned the passive system is the Vaccine Adverse Events Reporting System. That system is just going to contain information from persons that received a dose of vaccine. It requires the next step, the large linked databases of the Vaccine Safety Data Link, to have that information on people that both received the vaccine and then those that did not. And that's the way you can tell whether an outcome is caused by a vaccine. The Vaccine Adverse Events Reporting System, which we'll call VAERS, is a passive surveillance system. CDC and FDA relies on providers to report outcomes to us. When a clinician or a provider sees some type of outcome that's of concern to them following a dose of vaccine, we want them to report it to us, whether or not they think it's related to the vaccine. So we'll collect that information. We receive 10,000 of these VAERS reports a year, so it's a huge number. Of course, not all of them are related to the vaccine. It's a passive system. But what it does allow us to do, it allows us to collect perhaps that rare event that might have been missed in the pre-licensure trials. It does allow us as well to perhaps identify certain characteristics of people that report an adverse event because other information is collected in the VAERS report. There's some medical information as well. So it allows us to collect that. We collect lot information in a VAERS report as well, so it may be possible to link outcomes to particular lots of the vaccine. But again, I want to emphasize that it's a safety net. It's a way to collect the information. VAERS alone cannot provide any kind of answer as to whether a particular outcome is caused by a vaccine. That requires really more controlled studies that look at people that both did receive the vaccine and those that did not. THIMEROSAL is a preservative that's been used since the 1930s to prevent fungal bacterial contamination of vaccine that's given in multi-dose vials. Because the vial is repeatedly entered, you really need to take steps to prevent contamination. Thimerosal is a preservative that has been used since the 30s. In the late 90s, the FDA presented information about a substance similar to thimerosal. Thimerosal contains a compound called ethyl mercury. The FDA had evidence for a related compound, methyl mercury, that actually behaves quite differently from ethyl mercury in terms of its clearance from the body, in terms of the data that we have on the substance, being demonstrated as a neurotoxin. Methyl mercury, people kind of know that methyl mercury is a neurotoxin. It's a byproduct of environmental contamination of rivers and lakes. Mercury is ingested by fish. It becomes an organic product, and then the fish could be ingested by humans, and that's a problem if it contains methyl mercury. Ethyl mercury is different, but the FDA and the EPA had information about levels, and people compared that to the levels of ethyl mercury in vaccines. They were similar, so the CDC, Public Health Service, made a recommendation to remove thimerosal from vaccines. Turns out that that was not necessary for them to do. We've had studies since that shows that thimerosal is not harmful, does not lead to any neurologic outcomes at all. Neurologic outcomes was what was predicted because of what we know about methyl mercury, so they looked at that with ethyl mercury. No association at all, so thimerosal is a safe product. But because they had made that recommendation, you couldn't go back on that. And manufacturers began to retool their laboratories, and they stopped making multi-dose vial vaccine preparations. And as it stands today, none of the vaccines recommended for young infants contain thimerosal. There are preparations of vaccines that may be given to older children, the influenza vaccine, for instance. Some of the multi-dose preparations of influenza vaccine contain thimerosal. Other vaccines like TD may contain thimerosal as well. The rest do not. No live vaccine contains thimerosal. But it really doesn't matter because thimerosal is not a harmful substance. So really none of them given to the young infants contain it. Some inactivated influenza vaccine in the multi-dose vials contain thimerosal. I think when someone hears about an event, anecdotally, it does have a certain power to it, especially if it gets disseminated widely. But it's very important to realize that one event that occurs after a dose of vaccine very well may be a coincidence. It is very possible. You need to do further study to verify, what people may think is true. It very well may not be true, and it requires further study. Even though we're using more vaccines now than we did 30, 40 years ago, we're giving fewer immunogenic proteins in the vaccines that we give. And that's significant for a number of reasons. First, it's a testament to the improved technology of vaccine production, whereas in the past, our vaccine products required the use of entire, albeit attenuated, organisms. It was the entire organism. Smallpox was an example of this. The whole cell pertussis vaccine was an example of this. We used entire organisms loaded with thousands of proteins, and the potential for those proteins to cause adverse reactions, albeit mild generally, was there. Nowadays, if you look at all of the vaccines given routinely, the number of immunogenic proteins among those vaccines is 165. If you look at all of the epitopes on all of these vaccines, it's a much smaller number. We've been able to refine the technology so that we can use those parts of the organism that generate the immune response, and only that part. We've devised technologies to break apart organisms, and that often inactivates the vaccine, but it can still be used to generate a response. It requires more doses, so we've done that. We've found ways to express genes from the disease-causing organism in other products The hepatitis B vaccine and human papillomavirus vaccine are examples of this, in which certain genes from hepatitis B and human papillomavirus are inserted into what are called vectors, other organisms. Those vectors express the protein of interest, and then the protein is what's used in the vaccine. So it's a smaller number of immunogenic proteins in that product. So we have that. There's some vaccines for which we only use the capsule of the organism, the polysaccharide capsule. So there are fewer immunogenic proteins, and that's important in our communications. We can reassure providers and parents and the patients that these products do not contain as much immunogenic material, which drastically reduces the risks of any types of allergic reactions to the products. So, yeah, I mean, it's a testament to the technology, and it's also an improvement on the safety side of things as well. One reason it's important that vaccines have fewer immunogenic proteins is that what we're doing with a vaccine is we're artificially inducing an immune response. In order to do that, we need to have an antigen. We call it an antigen. It's that part of the organism that is responsible for generating the immune response. When you give the entire organism as part of a vaccine, you're giving not only those proteins that generate the immune response, but all of the other proteins that make up an organism, a being. I mean, humans are made of millions of proteins, and bacteria and viruses are the same way. They're made of many, many proteins, and some of these proteins are just unnecessary to have in the vaccine. They're structural components of the organism, and they are bound to generate not only antibody responses, but bring in other components of the immune response, those that are responsible for allergy-type symptoms. And so some may just be purely irritative, can cause irritation at the site of administration. That's what we see mostly with vaccines, is some local irritation. And that's what we would see multiplied if we continue to use whole cell organisms. So that's kind of, in a nutshell, that's it. You reduce the burden of foreign material you put in your vaccine, and you're bound to have a reduced adverse reaction. Vaccines have been called a victim of their own success, and what that means essentially is that vaccines have reduced the occurrence or incidence of these diseases by anywhere in the range of 90 to 100% for the vaccines for which the vaccines that we use. Because of that, providers, patients, their parents no longer see these diseases. So there's less motivation to use a product to prevent something if you don't see it. And it really does apply to both parents of patients and the providers as well. It requires a lot of education to talk about these diseases, explain that they are still out there, and that we need to vaccinate to prevent their occurrence. Another side of this is that no vaccine is 100% safe. Many have mild side effects. They are relatively uncommon, but they do occur at a higher frequency now than the diseases do. So more parents and patients and providers are going to see the side effects than are going to see the actual diseases, and that's a challenge as well. But it doesn't mean we stop vaccinating. We still have to vaccinate to prevent the diseases from occurring.